Hi class. In this lecture, I will provide you an introduction to autonomic pharmacology. There are some new vocabulary terms, so please review these and be familiar with them. The objectives are listed on the slide. They're also listed in your Blackboard module. We'll begin this discussion with an overview of the nervous system. So the nervous system is comprised of the central nervous system, which consists of the brain and the spinal cord. On the slide, you can see that in pink, and as well as the peripheral nervous system. And so the peripheral nervous system consists of all other nerves, all that blue spaghetti that you see on the slide. So to break down the central nervous system and the peripheral nervous system a little further, you can see some further delineation on this diagram. So today's lecture focuses on the peripheral nervous system. We will talk about the central nervous system a few weeks from now. So on the right side of the screen, you can see that the peripheral nervous system has several subdivisions. The first is the motor neurons and the sensory neurons. The sensory neurons, as their name imply, gather information about their surroundings. For example, heat, touch, pain, and they bring that information back to the CNS via the motor neurons. Via the sensory neurons. The motor neurons, on the other hand, carry information, commands, etc. from the CNS to the muscles and glands in response to that sensory data. We are going to focus on the motor neurons, and so the two subdivisions there are the somatic nervous system and the autonomic nervous system. So first, the somatic nervous system consists of somatic motor neurons. These control voluntary movement of muscles, like walking, reflexes, respiration, posture, things of those nature. There are drugs that impact the somatic nervous system. Maybe some of you are familiar with these drugs or have even administered these drugs. So they're called neuromuscular blocking agents. These drugs are considered high alert drugs, or drugs that, when used in error, are more likely to cause harm. Basically, if neuromuscular blockers are used incorrectly, they can be deadly. And this is a very important point. You must know this. I know some of you probably already do, but if you don't, pay attention now because these medications can be deadly when they're used incorrectly. The second division is the autonomic nervous system, and this is what the bulk of the lecture is about, although I will spend some time talking about the somatic nervous system and specifically those neuromuscular blocking agents that I just referred to. So within the autonomic nervous system, like I said, the autonomic motor neurons, these control involuntary movements, largely through regulation of functions of smooth muscle and glands. Now, the autonomic nervous system is further divided into two divisions as well. The sympathetic division, this is the division responsible for the fight or flight response, and that's when the body is confronted with acute stress-inducing situations. The body has a response mechanism to that. Obviously, this fight or flight was a really helpful response for humans to have back in the caveman days when people routinely had to flee from animals. Nowadays, we don't necessarily find ourselves in that situation all that much, but we can use that mental model to help us understand the fight or flight response and other similar responses that the sympathetic division is responsible for. We also call the sympathetic division the adrenergic system. You'll hear me use that term as well. The other division is the parasympathetic division. So this division is concerned with the housekeeping chores of the body. It's also known as the rest or digest system. And that's because Like I said, it's largely has to do with the housekeeping chores like digesting food, conserving energy, promoting growth, things like that. So keep in mind, almost all organs are innervated by the sympathetic and the parasympathetic nerves, and they largely work together to regulate the body's some of these processes within the body. So specifically, the autonomic nervous system functions fall into really three primary jobs: regulation of the heart, regulation of the secretory glands, and regulation of smooth muscle in places like the bronchi, blood vessels, the urogenital tract, the GI tract. And like I said, these activities are largely shared between the sympathetic and parasympathetic systems. As I mentioned, the parasympathetic is the housekeeper of the family, kind of conserves energy, controls vision. You want to think slowing down. So things like heart rate will slow down. Gastric secretions will increase in order to digest food. The body's able to empty the bladder and bowel. Eyes can focus for near vision. The pupil would constrict. Bronchial smooth muscle will contract. The drugs that work here are used for their effects on the GI tract, the bladder, and the eye. Sometimes the lungs and heart. There are a couple of very important drugs that affect the parasympathetic system, specifically the lungs and heart. We will talk about them, but that's not really, predominantly drugs in these categories will affect the GI tract, bladder, and eye. Poisons also impact this system. So we'll talk about reversal agents that can reverse the effects of poisons that can negatively impact the parasympathetic system. The sympathetic system, on the other hand, regulates the cardiovascular system and body temperature, as well as performing fight or flight response. So stimulation of the sympathetic system causes increased cardiac output, peripheral vasoconstriction, basically because the body's attempting to maintain the maintenance of blood flow to the brain. The stimulation can cause redistribution of blood during exercise, as well as compensation in the scenario of blood loss. So during fight or flight, the body orchestrates this response by increasing heart rate and blood pressure, by shunting blood from the skin and the viscera to the muscles. And if you think about it, that makes sense, because if you need to run away, you've got to have good blood flow and thus oxygen to those muscles so that they can work well. The body, during the sympathetic response dilates the bronchi, again, to improve oxygenation, will dilate pupils in order to take in more light, mobilizes energy stores to provide fat and glucose for the muscles. So again, all of these things kind of make sense, kind of in the context of that fight or flight response. So for me, as I was learning these, I tried to kind of put those different responses in those big buckets to make it easier for me to remember. Not everything fits nicely. Not everything the sympathetic system does is supporting fight or flight, but it's a good, for the most part, that you can make a case for that, and it's a good way to remember a lot of these actions. So in thinking of how the drugs work here, understanding what the system does will help you understand why we use certain drugs and the effects of those certain drugs on the heart, the blood vessels, the lungs, etc. So before I go on, I want to put in just a quick reminder for you guys. Keep in mind that most organs are innervated by both the parasympathetic and the sympathetic nervous system. Their effects could be opposite of each other, meaning they serve as a balance of sorts, like the picture we have here on the slide, where the heart is balanced by the parasympathetic system and the sympathetic system. In some cases, they're innervated by both and complement each other. For example, in the case of an erection and ejaculation, the parasympathetic and the sympathetic each are responsible for a piece of that, but they're complementary. Or rarely, only one division will innervate an organ. For example, blood pressure, I'm sorry, blood vessels are really largely only influenced by the sympathetic nervous system directly. Does that mean the parasympathetic nervous system doesn't have some indirect effects? Sure, it does. But in terms of direct influence, the sympathetic nervous system is the main force there. So we say that kind of on a day-to-day basis, the body has a typical autonomic tone. So those specific organs that are innervated by the parasympathetic and sympathetic system have a typical autonomic tone. Usually it's the parasympathetic tone. That's not always the case, but usually that's the case. And so that tone provides a basal level of control over which regulation is superimposed based off of the current info of the body. We're going to talk more about this at the end of the lecture. So just a quick reminder, how do neurons work? Because a lot of what we're about to talk about with regards to the autonomic nervous system, it is obviously related to neural physiology, which relies on neurons and receptors and neurotransmitters. So in case you had forgotten, let's just do a very quick cursory review of how neurons work, since all actions of the autonomic nervous system are through the work of neurons and neurotransmitters. So there are two basic steps in the process by which neurons elicit responses from other cells. One, you have axonal conduction, where an action potential travels down the axon to the presynaptic nerve terminal, where it then causes the release of a neurotransmitter. On the slide, that's depicted as a T. In the second step, the synaptic transmission occurs when that neurotransmitter travels across the cleft and binds to a receptor on the postsynaptic cell. And then ultimately, this produces a response as a result of that binding. So as I said, all actions of the autonomic nervous system are exerted through neurons and neurotransmitters. So a little more detail about the neurotransmitters. I want to mention this because the way many of the drugs work that I'll be talking about in the next lecture have to do with the potential actions of neurotransmitters. So if you look at this diagram, from precursor molecules, neurotransmitters are synthesized. So if you look on the diagram at the presynaptic nerve terminal, in step 1, you see precursor molecules that are ultimately being synthesized into a neurotransmitter, which is represented by a T in the diagram. In step 2, you see that neurotransmitter is packaged into a vesicle. And then at step 3, that neurotransmitter is released in response to an action potential. It travels across the synaptic cleft. And in step 4, it binds to a receptor on the postsynaptic cell and produces a response. At some point, the neurotransmitter in step 5 will dissociate from the receptor. So that terminates the action and further response from the binding of that neurotransmitter to a receptor. And then there are potentially 3 different fates that could occur for that neurotransmitter. In 5A, you can see that neurotransmitter is undergoing reuptake into the nerve terminal. In B, you can see what you see there is enzymatic degradation, so that T is kind of fading to represent that there's an enzyme that's degrading that neurotransmitter. Or in 5C, you can see that the neurotransmitter is just diffusing away from the nerve terminal. So I'm reviewing this because, like I mentioned, the drugs we'll talk about could work at any of these steps that I just described. They could work in the synthesis step, in the storage step, in the release step, in the binding step, or in the steps that occur after the receptor, after the neurotransmitter binds to the receptor. So keep this in mind as we talk about the mechanism of action of the various drugs. So now that you remember how neurons work, let's review neurons and neurotransmitters of the autonomic nervous system. Since that's how we classify these drugs, And like I said, understanding how we classify them, understanding how they work, will help you guys ultimately be able to apply this information in clinical practice. So first, let me orient you to the diagram. This is a high-level view of the peripheral nervous system. The first 5 sections that you see from the top down to the bottom, those are the autonomic nervous system. The last section is a depiction of the somatic nervous system. Like I said in the beginning of the lecture, when we talk about the drugs, most of what we talk about is going to be the autonomic nervous system. But we are also going to talk briefly about the somatic nervous system and specifically neuromuscular blockers. So I want to talk about the first half first, the autonomic nervous system, which consists of the parasympathetic nervous system and the sympathetic nervous system. So along the left side of the diagram, you see what kind of looks like a big worm. That big worm is the brain and the spinal cord, right? So all of these neurons are going to originate in the CNS. So the preganglionic neuron, so that's the first neuron. The preganglionic neuron originates in the CNS, and it's going to innervate at a ganglion. Another name for a ganglion is a synapse. And it's going to communicate with neurotransmitters to the postganglionic neuron. And that's that second neuron that actually leads to the end organ. So the postganglionic neuron originates in the ganglia and innervates the end organ. Frankly, when you look at this diagram, what we really talk about and what we really care about from the perspective of drug therapy is the postganglionic neuron and what it's doing at the effector neuron. The reason why is because if you look at those preganglionic neurons, so the first 5 preganglionic neurons, if you trace each one to the end, you see ACH. Do that for all 5. ACH, 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 ACH. ACH is acetylcholine. All of these preganglionic neurons release acetylcholine, and they all do that at the ganglion where the receptor on the postganglionic neuron is a nicotinic type receptor. The reason I'm pointing this out to you guys is because if you think for a minute, it's the same it's the same neurotransmitter and it's the same receptor, but yet look at all the different target tissues that are affected. If we targeted drugs at that first neuron and neurotransmitter, they wouldn't be very specific, would they? Because the neurotransmitters are exactly the same, and the receptors are exactly the same. So if we want to influence specific actions on these target organs, what we need to do is target the postganglionic neuron and the neurotransmitters and receptors at the target organs. And if you look at those very quickly, you can see some of them are acetylcholine. That ACH, remember, stands for acetylcholine. The M stands for muscarinic. But keep going down the list. Other neurotransmitters, if you look at the third line, NE is norepi. The fourth line, NE and D, which is norepi and dopamine. And you can see they've got different receptor types, some alpha, some beta, and then even alpha and dopamine. And then at the adrenal medulla, epi, norepi, right? So we've got a variety of receptor types and we've got a variety of neurotransmitters. And because of that, we're able to design drugs that are more specific for these end organs. All right, before I move on, let me quickly talk about the somatic nervous system. The somatic nervous system, you can see, kind of functions a little differently from the autonomic nervous system, right? There really is not a preganglion and a postganglion. There's just one neuron. So you've got that one neuron that originates in the spinal cord, and it extends all the way to the skeletal muscle and releases its neurotransmitter, which is acetylcholine. But again, it's a completely different receptor type. So you see that N there, you haven't seen that before. The N is a nicotinic type receptor. And so the anatomy of this system looks a little bit different, and then the receptor types that we see are different. And we don't necessarily call this the synaptic space, um, or actually maybe I should say really what we've got going on here is that one motor neuron that is innervating the skeletal muscle, and we call that the neuromuscular junction. So you'll hear me use that term. So like I said, the way we categorize these is based on what neurotransmitter is released and what receptor type is at the end organ, specifically for the autonomic nervous system. And this is where drug therapy is targeted. So from this moment forward, I don't want you guys to worry about the preganglionic neurons and what they release and where they do it, because there really is not drug therapy that we'll be talking about that targets that spot. But in terms of the autonomic nervous system, we're going to be thinking about those postganglionic neurons and what neurotransmitters and receptors they work with.
So let's start off by reviewing the parasympathetic nervous system, abbreviated PSNS. So I already kind of walked through this one as my first example, but uh, um, importantly, the parasympathetic nervous system is also known as the cholinergic system. And that's because the neurotransmitter released by this system is acetylcholine. So cholinergic comes from acetylcholine. Receptors at the target tissues are muscarinic receptors. So when we look at the parasympathetic nervous system, we're looking at the cardiac and smooth muscle, gland cells, nerve terminals. So the parasympathetic system, we're going to know that our receptors are muscarinic and acetylcholine is the receptor. What I don't want you guys to get caught up on is the preganglionic where it synapses with the postganglionic. You can see all of those are nicotinic receptors. They all use acetylcholine. If we targeted drugs for these particular receptors, they'd be very nonspecific in terms of their activity. So really, there aren't clinical uses for drugs that activate those receptors. So other than just pointing them out and you all knowing that they exist, we're really not going to worry about those. What we're going to worry about are those receptors at the target organs. So like I said, in the parasympathetic system, our receptor is muscarinic, acetylcholine is our neurotransmitter. There's one oddball that I do need to talk about. I know, when I teach the pre-licensure nurses, we also go over this content, of course, because it's such fundamental content. And sometimes they get a little bit hung up on this, but I know all of you guys will be just fine. What I want you to keep in mind is that the parasympathetic system, as I said, is muscarinic receptors, and the neurotransmitter is acetylcholine. There is one part of the sympathetic nervous system that also uses muscarinic receptors and acetylcholine, and that is the sweat glands. Now, technically they're part of the sympathetic nervous system, but really, don't get caught up on this. It's not a big deal. It's just kind of an oddball thing to remember. When we think about drugs that either act or block muscarinic receptors, we need to recognize that the sweat glands could be affected by that. So please keep that in mind. Okay, so final review, cholinergic system. So that is definitely something you want to know. So parasympathetic nervous system, also known as the cholinergic system. Neurotransmitter is acetylcholine, and our receptors are muscarinic.
So this is a close-up of a cholinergic nerve terminal. And you can see what's happening here when the cholinergic receptor nerve terminals release acetylcholine. They'll bind on the postsynaptic cell cholinergic receptor. It could be either nicotinic or muscarinic. And then what you see in the diagram is just the life cycle for acetylcholine. So this explains how acetylcholine is synthesized, how it's released, how it binds, how it's broken down. And just so you guys know, drugs could work at any of these different points. So we're going to talk about drugs that interfere with receptor binding of acetylcholine. So those drugs are called antagonists. They bind at the receptor and they block acetylcholine from binding. So thus acetylcholine can't produce its effect. We'll talk about drugs that mimic acetylcholine and bind at that receptor. We'll talk about drugs that influence the breakdown of acetylcholine. There's an enzyme on your slide. It's represented as a green box, ACHE. That enzyme is acetylcholinesterase, and that's the enzyme that's responsible for the breakdown of acetylcholine. So if you think about it, if we can block that enzyme, then we can reduce the breakdown of acetylcholine, and then there's more acetylcholine available for a longer period of time at that receptor site to produce its action. So I'm not going to, obviously at this point, go over all the different drugs and how they work, but when we start to talk about cholinergic drugs, you should be thinking back to this diagram and putting kind of into your mind's eye where that drug is affecting this receptor binding process. All right, so let's talk about those acetylcholine, or I'm sorry, let me say that again. Let's talk about those cholinergic receptors and what they do at their site of action. So remember, the parasympathetic nervous system, when we think of the parasympathetic nervous system, we're thinking of muscarinic cholinergic receptors because those those neurons release acetylcholine, and they interact with cholinergic receptors at the end organs that are muscarinic receptors. So I like this diagram. I think that it succinctly summarizes what happens when the receptors of both the parasympathetic and sympathetic nervous system are stimulated. Now, for the purposes of our discussion right this moment, you would want to look at the blue detail on this diagram, because the blue detail on this diagram describes what happens in the case of muscarinic cholinergic stimulation. So, for example, if you look at the eye, the expected action is contraction or meiosis. If you look at the heart, the expected action, or one of the expected actions, would be decreased heart rate or decreased contractility. The lungs, you would expect bronchial constriction as well as increased secretions. The bladder, relaxation of sphincters and bladder wall contraction. And the GI tract, increased motility and relaxation of sphincters. If you think of those things I just mentioned, they kind of go along with that idea of rest and digest, right? So as you're studying, you should know this chart for sure. You should know that when you stimulate the muscarinic cholinergic neurons, that these things happen. If you know this, when you start to study the drugs and you know that a drug is a muscarinic agonist and you know where in the body it acts, you can predict what that therapeutic response will be, for example. So obviously blockade is the opposite. So you don't necessarily have to remember everything that happens in stimulation and blockade. Just remember stimulation, for example, and then you know that the opposite of that would be the effects of blockade. Now, we do have a nice mnemonic to help remember excessive blockade. And when I say excessive blockade, I mean extreme overdose or maybe a poisoning situation. So this saying can be easy to help you remember what you might see. Mad as a hatter, which manifests as psychoses or seizures. Dry as a bone, so secretions are decreased. You have dry mouth, dry skin. Another way to remember this is dry sluds. So the dry is just decreased salivation, decreased lacrimation, decreased urination, decreased defecation, decreased sweating, for example. Blind as a bat, so the eye can't accommodate, can't see close, pupils can't constrict, patients experience photophobia. Red as a beet, so cutaneous blood vessels dilate. Hot as a hair, skin feels warm. And remember, what we're talking about here is that top part, those top two lines on our original diagram. We're talking about extreme blockade of the parasympathetic system as well as blockade of the sweat glands.
So let's move on to the sympathetic nervous system. This is also known as the adrenergic system. This system is called the adrenergic system because the neurotransmitter that is released is epinephrine. Epinephrine is also known as adrenaline. One of the other transmitters, or actually probably even more common than epinephrine, is norepinephrine or noradrenaline. So adrenergic comes from the word adrenaline. The final neurotransmitter that is used in this system is dopamine. Dopamine, norepinephrine, and epinephrine are all very similar chemicals. They're all synthesized in the body. Uh, Primarily, when we think of the sympathetic nervous system, we're thinking of norepinephrine. But like I said, epi and dopamine also could be used. So if you look at the system, I've got kind of the center of the picture highlighted. So you can see that we've got our preganglionic neuron, that's synapses, and then our postganglionic neuron that goes to our target tissues. And you can see at those target tissues, we have a couple different types of receptors, either alpha receptors or beta receptors. We call these alpha adrenergic receptors or beta adrenergic receptors. If you look at the second line, you can see that if we look specifically at renal vascular smooth muscle, that we either have alpha receptors or dopamine receptors, specifically dopamine 1 receptors. So specifically for the renal tissue, either norepinephrine or dopamine is the neurotransmitter, and then the specific distribution of receptors you can see there. The last thing I want to talk about is the adrenal medulla. The adrenal medulla is involved in the fight or flight response. So, going back to those crash course videos, when we talk about the sympathetic nervous system, we're thinking about the flight or fight response. And so that response is mediated through the adrenal medulla. So while there is no postganglionic neuron, you can see we've got our preganglionic neuron, that's synapses, at the adrenal medulla, and then the adrenal medulla will release either epi or norepi. And that epi or norepi is what's responsible for the flight or fight response. Okay, so in summary, you want to know that the sympathetic nervous system, or also known as the fight or flight part of the peripheral nervous system, is responsible for is not responsible, is innervated by adrenergic receptors. They could be alpha receptors, beta receptors. Those are the primary ones that we think about, but also dopamine receptors if we're talking specifically about renal tissue. The neurotransmitters that are involved are norepi, epi, or dopamine, and overall this system is referred to as the adrenergic system.
So let's talk about those adrenergic receptors. Adrenergic receptors, there are 4 subtypes. There are actually more than 4 subtypes, just so you know. But there are 4 primary subtypes that we are most concerned with. So just like in the parasympathetic system, there are specific receptors at the end organs that differ. And this is good because it allows some degree of specificity, right? So within the use of epi or norepi or dopamine, specifically norepi and epi, if you've got epi that's impacting that's binding at alpha 1 receptors of the blood vessels, that'll produce one response. Whereas if you've got epi that's binding at beta 1 receptors in the heart, that's going to produce another response. So from a drug therapy perspective, this is nice because we can target or develop drugs that only interact at the beta 1 receptors of the heart, allowing those drugs to have a high degree of specificity, for example. If this weren't the case, it would be really difficult or maybe even impossible to design drugs that influence the sympathetic nervous system without causing all kinds of intolerable side effects. So we call all receptors stimulated by epi and norepi adrenergic receptors. And these are found on postganglionic sympathetic neurons. Specifically, they're found at the end organs, right? So I kind of misspoke there a second ago. Really what's happening is the postganglionic sympathetic neurons are releasing epi or norepi, and then these receptors are on the target organ, and that norepi or epi that's released from those adrenergic neurons will interact at those receptors. Here's a close-up of the adrenergic receptor, and this depicts the life cycle of norepi. It looks kind of similar for epi or even dopamine. If you want, you can check your textbook and Your textbook might look a little different from this slide, but you can get a feel for what the life cycle is for those other neurotransmitters. This is just an example. So the primary neurotransmitter of adrenergic neurons of the sympathetic nervous system is norepinephrine. Now, I mentioned epi and dopamine also are neurotransmitters, but really the primary one is norepinephrine. So norepi is synthesized from precursors like dopamine. It's then stored as norepi in vesicles. When an action potential travels down the axon, it's released, and then it binds on those postsynaptic receptors on target organs, either alpha 1 or beta 1, and it produces a response. At some point, it dissociates from that receptor, and it either undergoes reuptake into the cell, into that postganglionic cell, or it binds to an alpha 2 receptor, which you can see on this slide, and it kind of acts like a shutoff valve. So the alpha 2 receptors is the only receptor type that we talk about that is on the postganglionic neuron. And it's basically a form of self-regulation. When there's too much norepi at the nerve terminal, some of that norepi starts to bind to the alpha 2 receptors, and it's like a shutoff valve for the postganglionic neuron to stop releasing epi or norepi. We're going to talk a lot more about alpha 2 in a future lecture. And again, just like with the cholinergic neuron that I showed you and the cholinergic receptors, these individual processes that kind of make up the life cycle of norepi or dopamine or epinephrine could be targeted by different drugs. Same picture I showed you before. This is just to help you understand what the effects are when these receptors are stimulated. So again, I highly urge you to remember this. Study this chart, understand this chart. This is incredibly helpful when you are trying to understand the pharmacology of the drugs. Again, if you know what happens when you stimulate an adrenergic neuron, if you know that a drug is an adrenergic agonist, and you know what receptor type it touches, does it impact the heart, does it impact, the blood vessels, etc., then you can easily ascertain what the response would be from that particular drug. So look through this. I'm not going to read this to you, but take a look at this and, like I said, spend some time studying it and getting to know it well. Obviously, blockade would just be the opposite effects of stimulation. So what I would recommend is just remember one or the other, and then when you're applying it to specific drugs, then you would just think, okay, what's the opposite of whatever part you've remembered? So I said we were going to come back to this slide once we finish talking about the anatomy of the autonomic nervous system. So keep in mind that most organs are innervated by both the parasympathetic nervous system as well as the sympathetic nervous system. In many cases, there are opposing effects, and that's because the body is very good at self-regulation. And the way that the body generally self-regulates is through feedback loops. I'm sure that you remember from pathophys this concept of feedback loops. As the body receives info, one system may predominate based on that info, but then as the body adjusts or as new information is coming in, the body could make changes based on that info. One of the most important feedback loops is the baroreceptor reflex. So essentially you've got sensors in the body that are providing information to the brain. The brain is providing cues to the body to do something about that information, right? So like I said, the baroreceptor reflex is one of the most important, especially from a pharmacologic perspective, related to the autonomic nervous system. So the baroreceptor reflex helps regulate blood pressure. This reflex is important to us because it frequently opposes our attempts to modify blood pressure with drugs. So when I say feedback, what I mean is just a reflex, right? So something the body does. in response. So that feedback loop is producing a response or a reflex, so to speak. With the baroreceptor reflex, there are baroreceptors. So these are specific receptors located in the carotid sinus and the aortic arch in the heart. They monitor changes in blood pressure and they send that information to the brain. So if we give a drug that lowers blood pressure, the heart is going to, these baroreceptors in the heart are going to detect that information. In response, the brain starts to send impulses along nerves to the autonomic nervous system, and that instructs the heart and the blood vessels to behave in a way that brings that blood pressure back to the previous range. Normally, in normal patients, that's a normal range, right? So in a normal patient, there's some, and when I say normal, I mean a patient without hypertension. There's a reason why their blood pressure is changing. Maybe they're losing blood. Maybe they've experienced trauma, right? So when the blood pressure falls, the baroreceptor reflex will cause vasoconstriction and will attempt to increase cardiac output. Now, these actions will help bring blood pressure back up. Conversely, when the blood pressure rises too high, the baroreceptor receptor reflex will cause vasodilation and that will reduce cardiac output, again, thereby causing blood pressure to drop. So when we start to talk about hypertension, we'll talk a lot more about the baroreceptor reflex. But if you just think of that conceptually, think about if we're actually attempting to lower blood pressure through the use of medications, the body is, because of these feedback loops that are all working together, will attempt to prevent us from doing that. And so that's why sometimes, our attempts to lower blood pressure for patients with hypertension don't initially work. We have to, add on additional drugs, and we're, in some ways trying to overcome that automatic response. So the reason I mention all of this to you is I don't want you to think that these two systems work in isolation, because they certainly don't. We can look at what we would see happen, what we would expect to see as a response in the sympathetic system, and what we would expect to see as a response in the parasympathetic system, but know that the body is constantly playing those two systems off of each other. And so when we see responses that look a little different from what we expect, then we kind of go back to the drawing board and start to think about why is that occurring. All right, so let's move on to the somatic neurons that also utilize acetylcholine. So technically they're cholinergic, although like I said, in practice we really don't call these cholinergic. We reserve that term for the parasympathetic nervous system and as well as blockade of, or stimulation or blockade of the sweat glands. So on the slide, I've got the somatic nervous system in that blue box. So that's what we're going to talk about now. So when you block the somatic nervous system, which is really the primary use of drugs that impact the somatic nervous system, what's happening is you've got neurons that are releasing acetylcholine at the motor end plate, and they're interacting with nicotinic M-type receptors at the neuromuscular junction. If you stimulate those receptors, then you would see muscle movement. So naturally, the body releases acetylcholine. If acetylcholine binds at those receptors, it produces muscle movement. If you block those receptors or blockade at that neuromuscular junction, then what you see is skeletal muscle paralysis. Therapeutically, we have drugs that are called neuromuscular blockers, and that is what they're used for from a therapeutic perspective.
And so this is just a summary chart that I made to help you master the information. This is really the bare bones information that you would want to know. I highly urge you to pay close attention to this lecture and make sure that you really understand the different divisions, what happens with activation or blockade, what the different receptors and neurotransmitters are that are involved. And so as you can see, I've got the neurotransmitters listed for each part of the peripheral nervous system, the receptors. Specifically for the sympathetic nervous system, you can see that I've listed the subtypes of receptors. Please be sure to know where each of those subtypes are largely found. and then the effects. And so I've only listed the effects of what happens with stimulation, but you know, of course, the opposite of stimulation is blockade, and so you can imagine the effects would be the opposite.
All right, so that's it for our introduction to autonomic pharmacology. In the next lecture, we will talk about um, the drugs of the autonomic nervous system as well as drugs of the somatic nervous system. If you have questions about autonomic pharmacology from this lecture, please post them to the discussion board.